A very good afternoon to all the listeners. I feel honored to participate in the 5th Middle East International Dermatology and Aesthetic Medicine Conference. And it's an honor to receive an invite from the organizing team and the scientific team for sharing my experience on periungual warts. I bring you greetings from the Nail Society of India, and I have no conflict of interest or financial disclosures to make. The present session will be organized in terms of first stating the problem, why we have issue with periungual warts, the solution in terms of reviewing the evidence on efficacy and safety of various injectable therapies. I'll also be sharing my experience with respect to the treatment results, and I'll also highlight the lacunae to summarize future directions. Ungual warts, as we all know, are the most common benign tumors of the nail unit, which involve fingernails more than the toenails. The lesions are very commonly seen, especially in the young population, and it's also an occupational hazard, especially in those dealing with meat, fish, poultry, or lots of wet work. Um, Fortunately enough, the benign types of HPV are the most commonly implicated. The lesions can vary, are most commonly asymptomatic, but they can vary in presentations from very small to very large lesions. They start as a rough hyperkeratotic papule, which may progress to a plaque, commonly from the lateral nail fold, the proximal nail fold, and less commonly may involve the hyponychium as well. Although the lesions do not generally affect the nail matrix directly, they do produce pressure effects leading to nail plate alterations. The onycholysis may be a result of the subungual extent of the lesion. You may see very inconspicuous lesions which are seen on immersion after immersion in water only. A larger lesion may lift up the nail plate or may even destroy it as is seen in this particular nail patient. The lesions are most commonly multiple, involving the periproximal nail fold, the lateral nail fold. Here you can see extensive involvement of the hyponychium also, not to forget so many cutaneous lesions which are present simultaneously in those particularly predisposed. So we all know that nail involvement is very common with either perianguli or subanguli. What is interesting is the involvement may be limited, isolated to the nails itself, causing a significant functional compromise for the patient. The important thing here to note is that the impact on quality of life is significant, but conventional therapies may not be effective because we cannot deal with routine topical application of drugs in this setting. The complications which the warts can lead to are fortunately few. These can occur in the form of secondary effects on the nail plate. Occasionally, they may cause bony erosions or spread to other areas, especially because they are present on the acral area, which commonly touches other parts of the face or other parts of the body. Very rarely, development of pre-malignant lesions has also been reported. The differential diagnosis which we may need to entertain in these cases are sufficiently rare, are fortunately rare. These include tuberculosis vericosa cutis, especially in populations which are prone to develop tuberculosis, and immune populations as well. Onycholemmal horn, which is a subungual tumor. Onychophosis, or presence of a subungual corn, can mimic the presence of a wart. It may be confusing at times. Whereas subungual filamentous tumors like the onychopapilloma may be a cause of confusion at times, and Bowen's disease should be kept in the differential diagnosis, especially if there is new onset of single lesion in a person who's in the elderly age group. The diagnosis should be achieved as early as possible because that offers you a distinct advantage because it helps you control the lesion even before the spread has started to occur to other areas. In this respect, onychoscopy is particularly useful because it helps you identify the typical vascular pattern for warts, even in the small periungual lesions. For example, in this subungual growth kind of a thing, where there can be many differentials if you look at it clinically, The diagnosis was clinched on the basis of onychoscopy, which showed the presence of these small hemorrhages surrounded by wide structureless areas, which are the papillae of the wart. Similarly, in this proximal nail fold, hyperkeratotic lesion in the proximal nail fold, these small hemorrhages go on to suggest that you are dealing probably with a wart. The dermoscopic features of verrucae are very specific in the form of presence of group papillae with dotted or looped vessels. The papillae are typically centered with a hemorrhagic dot. The hemorrhagic points may also be surrounded by a peculiar whitish halo. At times, if the lesion is particularly exuberant, it may give a frog spawn appearance. Histopathology is the second investigation modality, which you may rarely require, especially if you're concerning, if you want to rule out differential diagnosis like Bowen's disease or any other subungual tumor. Here you see the typical presence of coilocytes in the hyperkeratotic or the acanthotic nail bed epithelium. Treatment. Coming to the treatment aspect, which is often frustrating for these patients because of the low cure rates achieved with the conventional therapies and a high rate of recurrence. Now, this high rate of recurrence here has to be taken with a pinch of salt because the lesions present in such acral areas are predisposed to aid the spread to other parts of the body, and that is why they should be treated more carefully and more aggressively, let's say. The lesions are known to spontaneously resolve over a period of 4 to 5 years, but then this period of spontaneous resolution is not applicable to mosaic warts, which are commonly again present in the palmoplantar location. For large and long-standing warts, which these lesions, the ungual warts, tend to be, or warts which are seen in the immunocompromised patients. Various treatment options are known, just as they are known for warts in other areas of the body, and these include the topical therapies, systemic therapies, surgical therapies, and intralesional therapies. Topical therapies have been known to be the first line management in limited area involvement or limited number of lesions, but they have their obvious drawback when it comes to the nail unit because a large part of the lesion may be covered by the nail plate itself, making the application of topical therapy to the warts which are ungual in location all the more difficult. Because of this, keratolytics, glutaraldehyde, formaldehyde, or topical sensitizers and imiquimod may achieve only a limited level of efficacy when it comes to ungual warts. Systemic treatment for warts is also known, and these are mostly immunomodulators in the form of oral cimetidine or interferons. But again, they may not be justified for the limited number of lesions which are occurring in the acral area, and at the same time, the systemic side effects may not warrant the continuation of these therapies. Then, these being forms of immunotherapy, the efficacy of these treatment options is also less as compared to other treatment options. Surgical options have been reviewed in literature from time to time. These include cryotherapy, surgical excision, electrosurgery with your electrosurgical unit, the use of lasers, the ablative lasers, especially carbon dioxide laser and erbium YAG laser, and even the vascular lasers like the pulse dye lasers have been used in the treatment of warts, considering the highly vascular nature of these lesions. But there are inherent problems with surgical therapy also, which I'll just be discussing further. And these are generally reserved for the more recalcitrant lesions which you have not been able to treat. The next categories of injectable therapies regarding which I'm going to talk today. Most of my talk is centered on that. And these include the intralesional use of bleomycin, which is an anti-cancer drug, and vitamin D3, which again acts as an immunomodulating agent. In this 2001 article by Tosti et al., they had highlighted that for periungual skin, cryotherapy may be considered as the first line option. But here the problem is that it may cause underlying matricial damage and even recurrence may occur faster. But for lesions on proximal, lateral, and distal nail fold, they had suggested intralesional bleomycin. And for lesions on the nail bed, you would require laser. But to treat lesions on the nail bed, you have to first remove the overlying nail plate to expose the extent of the lesion and then treat it. So Uh, treatment is currently, we know after reviewing the literature that there is no particular evidence-based approach on which area of the unit, nail unit, are you going to treat with which treatment modality. There is no definitive cure guaranteed by any treatment. The treatment largely depends on the number, location, age, immunological status, and the experience of the treating physician. As far as possible, we should restrict the surgical approaches. Initially, I used to treat these warts with the help of nail avulsion, partial or total, depending on the extent of the lesion, followed by radiofrequency ablation of the underlying lesion which we exposed. So this was the kind of treatment that we were going in for. And here you can see that there is a regrowth of a normal nail after a period of time, because both lateral nail folds were involved with a significant extent into the nail bed. The removal of the nail plate was followed by electrosurgical ablation and then allowing the nail plate to grow. In this particular, only one lateral nail fold was involved. So this wart was treated with partial nail avulsion followed by RF ablation. But you can see that even though the rest of the nail plate is going back, there is significant scarring over the nail bed, and it is highly unlikely that this nail plate is going to adhere. In another case where there was a very extensive hyponychial lesion extending onto the subungual area, the what we realized was even after total nail avulsion and electrocautery of the lesion, by the time the nail plate was growing back, the wart was also growing back. That would necessitate further nail plate avulsion, which is not agreeable to the patient or to the physician. Similarly, in this case, very resistant lesion, even after 2 to 3 sittings of electrosurgical ablation, it is not responding. So slowly we just gave up on this approach and we move on to the next pattern, which is the injectable therapy in the nail unit. Why do we need injectable therapy in the nail unit? Because it can treat the unreachable parts. For example, for a subungual lesion, now I do not have to remove the nail plate to deliver my drug. It achieves effective levels of drug at the site of action, avoiding systemic circulation or first pass metabolism of the drug. So the systemic side effects are totally avoided. It establishes a tissue depot for prolonged drug release only for drugs where it is applicable and maintains an effective level of the drug to prevent subsequent relapse. The nail as a unit, we know, offers difficulty in topical drug delivery because of the thick nail plate and the double fold of the proximal nail fold. The slow speed of the nail growth means that the duration of therapy is also going to be prolonged, which means there is questionable long-term compliance, which means that there is significant toxicity of systemic agents. Hence, injectable therapy becomes the treatment of choice in these cases because you are dealing with a very limited part of the body where you can deliver your drug without causing systemic side effects. The site of injection is determined by the particular feature of the of a particular feature of the lesion that you're trying to treat. And in this case, today's discussion, that is the periungual warts, we'll be using a translesional injection where the drug is injected within the lesion, suffusing it. So injectable drugs in the form of intralesional bleomycin and intralesional vitamin D3 can be used translesionally in the warts. Bleomycin comes as a dry powder in a 15-unit vial. The drug is reconstituted with the help of 5 millimeter of normal saline. Here you see me injecting into a new vial which has been recently opened. Now, once reconstituted, this forms a 5 milligram per ml solution, which is a clear solution. There should be no residue. Now, once you reconstitute this drug, it needs to be, the date of reconstitution needs to be clearly labeled and it has to be stored at 4 degrees Celsius in a fridge for a maximum of 60 days it is viable. And you need to withdraw small amounts of this drug into an insulin syringe, which will now be used to inject the drug into the wart that you are trying to inject. So just to revise, 15-unit bleomycin dry powder, which is kept in the fridge, is reconstituted with the help of 5 ml of distilled water or normal saline to constitute a stock solution of 3 unit per ml, which has to be kept at 4 degrees Celsius for a maximum of 2 months and used thereof as and when you have patients. Vitamin D3 injection comes as a 60,000 international unit injection in an oily base, which is injected just beneath the wart. Maximum dose of 0.4 ml per session. Both the drugs need to be repeated at two weekly intervals depending on the response to the previous injection. The translesional injection is administered this way as per the schematic. This is the direction of the needle and this is the area of drug infusion which is achieved with the help of the injection. Just to see, please notice that I'm using the insulin syringe, which has the thinnest possible needle, the 30 gauge needle. It's an inbuilt needle, so there is no risk of backsplash or dislodgement of the needle because you are doing an injection under pressure. Please note the blanch arising in the lower part of the wart and the appearance of droplets of the drug on the surface of the lesion. So with the lower part completely blanched, now I am injecting within the substance of the wart to completely blanch the upper part of this periungual wart as well. This is the kind of endpoint that you are aiming to achieve at the end of, and this has to be done for each and every wart that you are injecting. Here, if you can see, the same injection being given into a larger wart, the end point of suffusion here is the appearance of small droplets at the surface of the wart, where you can see that the lesion has been completely suffused and there is a blanch which occurs. Bleomycin can also be injected with the help of a bleopuncture technique, where that same needle is used to produce multiple small punctures into a flatter lesion where you are not confident about injecting. So you produce multiple punctures and there is a small amount of fresh bleeding from that lesion and you put a drop of bleomycin over that. So this is how you do a bleopuncture. So the concentration of the stock solution, if you remember, was 3 unit per ml. It can be injected in terms of 1 to 3 unit per ml. I use 3 unit per ml start now, but for the beginners, you can start with 1 unit per ml being injected and the dilution can be achieved further with normal saline. The amount injected depends on the size and number of warts, but generally for an average size wart, you will never need to inject more than 0.1 to zero point 0.2 ml. The endpoint is the blanch of the lesion or appearing of small droplets on the surface. Post procedure, we tell the patient that you can expect a blackening of this blanched lesion by the evening with necrotic eschar formation, which will slowly start falling off over further 2 weeks. During this duration, the patients are advised to liberally use heavy duty emollients uh, uh, wipes of paraffin, which eases the exfoliation and keeps the lesion moist. The patient needs to report any post-procedure pain or bluishness, but there is no regular need for antibiotics or painkillers. There is another study we recently published in this year only, which gives this bleomycin drug after doing a fractional CO2 ablation of the lesions, which is by the same logic. In my experience, I've just tried to summarize some of my experience treating warts in the ungual location and simultaneously the palmoplantar warts of the same patient, which is another location very usefully treated by bleomycin. As you can see, there were 5.44 warts per patient and the number of sittings required was 3.04 visits per patient. These sittings are being done at 2 weekly intervals. Commonly, these patients present with multiple warts in the hands, as you can see, and this is the kind of response that you expect over a coming period of time. The lesion slowly regresses with these areas of necrotic eschar formation, which keeps on falling off, and then you can inject 2 weeks later once the lesion has assumed a normal morphology, and this is the kind of end result that you can expect. It works for multiple lesions which are present in different locations, and this is the kind of result that you can see in most of the lesions and even in the smaller lesions which can be cured. Another such case, you can see the response being produced by a lesion which, if would have been treated with electrocautery or cryosurgery, would have surely produced a lot of scarring. The response being seen in so many lesions here, just to highlight that a lot of emollients need to be used to maintain this response and so that the patient is not symptomatic. Bleomycin is also equally useful for the cutaneous component because the same patient may be having multiple skin warts simultaneously. Palmar warts, which tend to be palmar plantar warts, which tend to be very endophytic lesions, also can be treated very successfully with bleomycin either by injection or by bleopuncture. Warts on the dorsum of the hand also respond beautifully. These are multiple palmar lesions which resolved. The periungual and the subungual extent of this wart is very evident. So if we start removing the nail here and then treating, then it is surely going to cause scarring. But with bleomycin, we can achieve very effective results, like in these lesions as well. This subungual lesion, here you can see, just fell off after a period of 2 weeks with the single injection. The second time I just did a superficial bleo puncture for this patient. Coming to the side effects, the major disadvantage is pain. But here I would like to highlight that the injection is to be given within the lesion. So if pain is occurring, that means your injection is somehow transfusing into the normal skin. Pain is a marker of that. So please be careful while injecting in these areas. Can occasionally form subungual hematoma. More commonly, what we see is an injection site post-inflammatory hyperpigmentation and to some degree a disturbed nail growth. The risk of hypersensitivity reaction and vasovagal syncope has to be kept in mind, just as it is to be kept in mind for other injectable therapies. You need to be careful about that. Just to minimize the pain, you should use the thinnest needle, that is the 30 gauge needle of the insulin syringe. Inject very slowly. Keep talking to your patient all the time. Topical anesthesia may help you only marginally. I generally don't use it, but prior exposure to ice packs or simultaneous application of vibration or pressure to that same limb helps reduce the procedure associated pain. The side effects are minimal, which we noticed. These occurred in the form of a mild disturbed nail growth, an post-inflammatory hyperpigmentation, the formation of a necrotic eschar which turns painful for the patient or becomes secondarily infected at times, or a very severe exfoliation for which the patient has to be diligent about emollient application. So to conclude, there are no evidence-based approaches for warts. Your treatment choice will depend on the number, location, age, immunological status, and your experience. But bleomycin is a very reliable alternative for periungual, subungual, palmar, and plantar warts, which are typically the most difficult category of warts to be treated. You just need to pay attention to proper surgical technique, injection technique, and share good results. With this, I thank you very much for your kind attention. Thanks a lot.